Hey everybody, so welcome to my new YouTube channel. This is actually my second channel. The first one is called Physicians for Wishes. So on that channel, I'm granting wishes to cancer patients, to nursing home patients, and doing community give back videos as well. So Christmas toys to entire schools, feeding multiple hospitals pizza, in addition to a Valentine's video that I did providing gift baskets to every single cat and every single dog at an animal shelter. Overall, to be honest, I just got tired of watching TV medical dramas and just picking them apart. Rather it's Grey's Anatomy, Good Doctor, House, Scrubs, and I'm wondering, is it a Hollywood doctor that's behind the scenes for these scripts, or is it actually a full-time practicing ER physician or surgeon? So my name is Dr. Taylor, and I'm a board-certified emergency medicine physician. I'm also an Air Force flight surgeon as well. I'm on staff full-time at multiple different hospitals, ranging from small community hospitals to large academic trauma centers. So this first review is Season 1, Episode 1 of The Pitt, airing on Max. Now I wanted to choose something that was just released, brand new episode, and then start focusing on some of the other medical dramas. So this one is based in Pittsburgh and focused on healthcare professionals in the ER. Now there are a total of 15 episodes in the first season, corresponding to a 15-hour shift. The first episode takes place just in the first hour as an ER doctor. This TV series is supposed to show you just a little bit of what we go through as ER doctors. Now, not all of us do 15-hour shifts. Some do 8 hours, some do 10, some do 12. Occasionally I'll do a 24-hour shift. So it does vary. So let's go review the first episode.
Healthy 31-year-old VTAC arrest 2 weeks after triathlon. NSR with 1 shock.
Pulse 98, BP 110/60.
He's a little young for the mind.
Exactly right. What's the differential, Dr. Collins?
Drug overdose, electrolytes, on QT, Brugada syndrome, WPW.
So here he's asking for the differential while assessing the patient. This is actually a pretty good differential.
How you doing there, Otis?
Okay. What happened?
VTAC again?
200 joules.
Charged and clear.
Since there's a change in mental status, this is actually going to suggest that there is inadequate blood flow to the brain, decreased perfusion, and this is likely because of the abnormal rhythm.
Back in sinus. Otis?
He's looking at the monitor and sees a wide QRS, he sees peak T waves, and so that can be seen with severe hyperkalemia.
Otis?
So this one's interesting because the attending is actually drawing up the med, and in reality, it's the nurse that typically draws this up, but he's also not really informing any of his team at what's going on, his thought process. As an attending myself, you're going to communicate with your team. You're going to let them be aware of what's going on.
Oh, groaning's good. 5 of nasal, O2, CBC, CMP, troponin, and D-dimer.
There's no mention of hypoxia at all. And if you want to put 2 liters for comfort, that's pretty reasonable. But I think jumping right to 5 liters is probably not the best choice.
What are you doing?
1 gram calcium gluconate, IV push.
Now, the medication he mentions here is calcium gluconate. That's a correct medication, but it's not the right dose. So we're either going to give 2 to 3 grams of calcium gluconate IV, or we're going to give 1 gram calcium chloride through a central line. Overall, this is just not enough calcium. So I think if you're going to mention dosing on TV, just mention the dosing accurately. Otherwise, just say, hey, I need calcium or something related.
We don't have the labs back.
Look at the monitor. Wide QRS and peak T waves, hyperkalemia.
How do you get that?
Intense exercise caused muscle breakdown, rhabdomyolysis, knocked out his kidneys. Now he's not clearing potassium. I bet it's over 7.5.
If you've progressed to not just peak T waves, but also a wide PR, a wide QRS, this actually then leads to a loss of the P wave, it leads to a sinusoidal wave, and then ultimately that's your cardiac arrest. So essentially the triathlon led to muscle breakdown and necrosis. We call that rhabdomyolysis. And if that goes untreated and it continues to progress, that's your renal failure, that's your kidney failure. And then that progresses to a multitude of electrolyte abnormalities like hyperkalemia.
Wait 2 minutes for the ice.
If you arrest him, we might not get him back.
Calcemia, you could kill him. Wait.
It's my ass, not yours.
So here, the senior resident's actually arguing with her attending. This is not appropriate. And at the same time, she asked, can he wait 2 minutes for the I-stat? So these are point of care labs that we get back pretty fast. He could probably wait 2 minutes, but I would argue this is a patient that already has a wide QRS, peak T waves, that's already suffered a VTAC mimic a couple times now. This patient needs cardiac stabilization.
QRS is narrowed. Much better.
Potassium is 7.7, creatinine 5.6.
High potassium and renal failure. Just what you thought.
Must be my lucky day.
Ordering 10 units of regular insulin and 25 grams of glucose.
Why insulin and glucose?
Shift the potassium intracellularly.
So the first line treatment is to stabilize the myocardium. So we're either giving calcium gluconate or calcium chloride. Next, we want to shift the potassium intracellularly. So it's correct when they said, hey, I need 10 units insulin and AMPA D50, because insulin is going to shift that inside the cells, and the AMPA D50 is going to prevent the glucose from going lower. Now, obviously, if the patient is severely hyperglycemic, that's a different story. What they didn't mention is albuterol is often used, and it will be used every single time when a potassium is this high. 10 to 20 milligrams of albuterol, not for the shortness of breath. It also shifts it intracellularly as well. Now, while you're doing all this, you also want to promote the excretion of potassium. Lasix and Kexley take hours to have effect. And in theory, you should be stabilizing the myocardium, given the insulin, given the albuterol, in addition to setting up for dialysis, putting in the catheter, doing all these things acutely. And you may even have to do them 2 or 3 times while you're waiting on that patient to get dialyzed.
Exactly, but the definitive treatment is...
Hemodialysis, I'll call renal and get a tech down with the machine.
Have you ever seen a dialysis catheter inserted? Dr. Collins is going to place a femoral quinton under ultrasound guidance. It's an excellent way to learn.
You struck my heart.
Long story. Dr. Collins will fill you in.
Muscle breakdown and myoglobin damaged your kidneys.
Why'd you shock my heart?
When your kidneys don't work, potassium builds up and messes with the electrical activity in your heart.
Can it happen again?
We gave you medicine to lower your potassium, and you'll need dialysis to clear it all out.
Then I'll be okay.
Yeah. You might need a week or 2 for your kidneys to recover, but yeah. You really need to hydrate like crazy before and after a triathlon.
Trust me. I won't let this happen again.
Good. Be kind to yourself, okay?
She's gonna miss the morning arrival of the living dead.
How many are we expecting?
We're getting 3, but 1 died en route. I don't know who's luckier, us or them.
What's open?
14.
89-year-old woman from a SNF.
So a SNF is a skilled nursing facility.
History of emphysema, CHF, MS, VFib, unresponsive to 3 shocks, 2 rounds of epi.
What is that?
Lucas chest compression system.
Robotic CPR.
So the Lucas device is something that we commonly use in the ER for cardiac arrest. It's providing consistent compressions at a fixed rate. So it's also helping with a cardiac arrest that's prolonged. It requires a lot of staff. Typically with these cardiac arrests, we have techs alternating with CPR. We'll have nurses doing this as well. In addition, med students, residents. I just happened to do it last week as well. So we have, a lot of staff depending on how long these codes are going on for. In the field, it's also used by EMS coming in because it helps, being able to provide CPR and transport if the conditions of transportation are making it difficult.
I'm gonna get a hold. 1, 2, 3.
So you'll notice here that the Lucas device is barely doing CPR. I wouldn't even call this CPR. This is Princess CPR. Again, this is a TV show, but if our goal is to be accurate, then we need to be doing accurate CPR. Now, we do have realistic bodies that can be used for this, or even if the editorial cut is just right, we can give that appearance. So the American Heart Association recommends 2-inch depth for adults, not more than 2.4 inches. So here we barely have anything, and I'm pretty sure watching this a few times, that Lucas device actually stops at the chest. Overall, I think TV shows need to stop showing us Princess CPR. I think for those that are non-medical, watching CPR done on a TV show kind of gives a false representation of what true, accurate CPR is doing. When we do CPR in the ER, ribs are broken, the sternum can be broken, we can even cause a pneumothorax. There's a lot of things that go on when CPR is done correctly. And just last week, I had a patient, when discussing code status with the family, they said, oh, I've watched CPR done before, and it's pretty okay. We'll definitely recommend CPR on my 90-year-old. Well, you ask them, well, where have you watched it? Oh, I watched it on TV. And this is true on so many different occasions that we hear this in the ER.
Students are dropping like flies. It's Take a break, ice the finger.
You can count on getting a couple elderly patients every day around 7:30 after the nursing homes and assisted living facilities do their morning bed checks. You can practically set your watch.
So watching this next scene, I actually have no critique for this at all. This is just plain accurate. The majority of the nursing home patients that I would say that I get on a shift on any given day, typically, it's happening when staff is doing rounds on the patient, they're doing bed checks, they're administering medications, and they notice that grandma and grandpa is now unresponsive, and now it's unclear how long they've been unresponsive for.
Was there an advance directive?
No, full code for the nursing home.
Seriously.
So this next part, I really critique the EMS report itself. Now, the patient had a cardiac arrest en route to the hospital. So what we know is that the patient was in refractory VFib, a shockable rhythm ×3, but how long was CPR going on for? Was it 10 minutes? Was it 15 minutes? This changes everything. Was it 45 minutes of CPR? That's much different than they had just started CPR in terms of getting this patient back. So there's a lot more detail that we need to know about this situation.
Lucas off.
Still VFib.
Lucas on. One more round of epi, one more shock, and then we call it.
So when this patient arrives, they immediately arrive at the conclusion the patient's still in VFib, they're going to do one shock and one more round of epi, and then they're going to call it. Now, if this is my patient, how about we confirm ET tube placement, have a listen to the lungs, do they course bilaterally, any physical exam at all. What about the pupil size? Are the pupils reactive? Any cardiac ultrasound? No physical exam was done here. The patient literally arrives, they make their judgment without any physical exam, and that's it. Now, if I told you I had an 89-year-old patient that was in refractory VFib, only underwent 3 rounds of CPR, and has reactive pupils, you're going to give medication. You're going to continue shocking that patient. You're not just going to call it. Now, as an ER doctor, calling time of death is probably one of the hardest things that we have to do because it's going to change based on risk factors, based on the clinical presentation, based on family, based on all these different dynamics. Are we getting a 4-year-old in cardiac arrest? Are we getting a 24-year-old in cardiac arrest? Are we getting a 100-year-old in cardiac arrest? And how long has that been going on for? Generally, your younger and healthier patients, you're going to code them for quite some time. Our older patients that have a lot of risk factors, you're coding them less. But we still do a detailed physical exam. We still ask the right questions. We still get the EMS report before making that call every single time.
And stop. Call it. Nursing home just faxed us a DNR.
So this is unfortunate, but this does happen. The patient was undergoing resuscitation, actively getting CPR and medication when they got the report, hey, the patient is no intubation, no CPR, etc. So, this happens, the family shows up, they make the decision to stop or withdraw care, or the nursing home finds paperwork that does in fact indicate that they wouldn't have wanted any of this, and of course it stops. So this does happen. This is actually pretty accurate.
Are you kidding?
Power out the defibrillator and the Lucas.
Complete waste of time and money. Who the hell works at that place?
A nurse taking care of 60 patients who couldn't find the form.
She called 911 so she could take care of the others.
So all ER docs have had this happen at one point or another. And for the resident to respond like this is just plain unprofessional. In this case, the nursing home, the staff, they tried to find the paperwork that they can. Maybe this was a patient that was new to this particular facility. As far as they knew, this patient was a full code. And so the fact that they finally found the paperwork, they let the staff know that it's completely appropriate. But how this resident doctor is responding, that's unprofessional.
Okay, let's move her to the viewing room and notify the family. Yeah. One of the things we do here is to take a moment of silence when we lose a patient. To respect their humanity and also to remember that this was somebody's child or sibling or parent.
So I have no critique about this. I just love this part, and I do this myself. Every time a time of death is called, it doesn't matter the age, it doesn't matter the situation. I think the entire staff that was in that room needs to take a moment of silence. Again, this could have been a grandma, a grandpa, a mom, a dad. This could have been a brother or sister. So taking a moment of silence is important. And I think for the attending in this case to really stress it to his residents, be like, hey, no, you're going to stay here and we're going to undergo this moment of silence is awesome. I love this. This happens all the time.
Friend.
So I guess it's again with this resident. So again, if this was mine, his attitude is going to be an issue. It would probably be an issue to other staff members as well. At the end of the day, you need to show some respect towards someone that just passed away. Show some respect to the situation. You know, being antsy, jumping up and down, almost like you don't want to be there. That's just unprofessional again.
I'm so sorry.
Maybe leave it on vibrate while you're working?
Otis's BP is crashing, 70/50, still waiting for dialysis.
How you doing there, Otis?
Okay, that's okay.
15 liters non-rebreather, please.
So if you recall, this is actually the same patient we had earlier that suffered a rhabdomyolysis-induced renal failure and severe hyperkalemia. And so they were waiting dialysis. And so this is kind of a continuation of that. And so what we see here is the patient's still in the ER. They're still awaiting dialysis, and the clinical picture and the clinical presentation changed.
Oh, crap. Diastolic collapse of the right atrium and right ventricle.
Tamponade from uremic effusion.
That's why his BP is low?
Yep.
Too much fluid and pressure around the heart. Chambers can't fill.
Otis, you got some fluid around your heart. We need to get it off.
Again, I applaud the writers for this one. You know, the patient was hypotensive, tachy, short of breath. For the residents and, you know, attending to go right to the cardiac ultrasound in this case was absolutely amazing. So they're seeing right atrial collapse, right ventricular collapse. They're seeing some fluid around the heart itself. Again, the right side of the heart is a low pressure system. You get enough fluid, it's going to put pressure on that side of the heart, on the heart overall, and you're going to get hemodynamic compromise. So renal failure can have multiple complications, as we've seen with the severe hyperkalemia and now the cardiac tamponade.
25 in propofol, 10 cc's of lidocaine with epipericardiosynthesis tray.
I have to get them from
No,
Central.
just open a central line, kid.
So the treatment for the cardiac tamponade is a pericardiocentesis. In this, we take a needle and we insert it within the pericardial space and we remove the fluid that's in there and it relieves the pressure from around the heart.
Dr. Santos, take the head of the bed and bag him if he stops breathing. Compression until we lose the carotid. Prep a drip to subxiphoid, please. 10 cc's of 1% width.
Chlorhexidine here, 25 or
No,
27
log
gauge.
25, log 25. Thank you. Injecting lidocaine.
Pressure down 60/40.
Right. Wait, you can't ultrasound in place.
I know, that's why I'm taking the probe. 18 gauge thin wall on a 60 cc syringe, please, Dr. Collins. Let's go. You're going in right over the center of my probe. Advancing very slowly.
Now, there are a few different ways to do this. Looking here, they're definitely going the subxiphoid approach. So this is typically done at the left costal margin. They do appear to be doing it there, but the needle needs to be angled downward, but towards the left shoulder at a 40-degree angle. So again, you're angling towards that left shoulder. Now, when we watch her do this, you can see that she's not angling to the left shoulder at all. She's nearly directly down. She's also just sticking the needle in, which is fine at first, but just realize as you approach the right ventricle, you need to be pulling back on that plunger to ensure that you're in the right space, even with the ultrasound. Now, I would actually expect her to have complications from attempting this way, bleeding, pneumothorax, puncture of one of the organs, and overall just not hitting the space because she's angling not towards the left shoulder. So the attending should have spoke up here and be like, hey, we got to angle towards the left shoulder a little bit more.
Looking for the hyperochord tip. Very, very slowly. Do not hit that hard. Dr. Santos, you see that sea of black? That's the effusion. We're looking for a little white dot. There it is.
Got it. Aspirating.
3 cc should be enough.
So one thing I've actually been asked before is, hey, that pericardial fluid that looks like a straw color, it looks like a clear yellow color, I thought it's supposed to be red. And in uremic pericarditis, uremic cardiac tamponade, that is the correct color. That's what it looks like. When it's cardiac tamponade from like a trauma or something else, it's going to come out bloody. It's going to look red.
Good. Next, we'll place the guide wire and then the triple lumen catheter.
Pulse ox is 99. Pressure's up, 124/78.
Looks like things are back to normal.
So let's get this guy dialyzed already. So this concludes season 1, episode 1. So overall, great episode. I do look forward to the rest of the season. So stay tuned for the next review.